1 in 5 children wet the bed by 5 years of age, and when it goes to 10 years, it can go down to 1 in 10, and roughly about 1 in 50 can continue to wet till puberty and sometimes in early adulthood. Bedwetting is more common in boys than the girls, and there is no defined pathogenesis. However, it is assumed that girls tend to be maturing faster, and that's how they escape having the less burden of this entity. There are multifactorial reasons. Some children can inherit it, so about 40% of children can have hereditary or familial enuresis, and it is supposed to be autosomal dominant in various studies. Most commonly, the reason for enuresis is delayed bladder and brain coordination. So the bladder is not maturing enough to send the signals, or brain is not maturing enough to receive the signals. However, it can be secondary sometimes to other factors such as kidney or bladder defects, neurological issues, or sometimes even emotional and psychological issues such as bereavement in the family, or arrival of a new sibling, or sometimes even child abuse. Yes, the treatment consists of various modalities, and it initially starts from the behavior reinforcement, which includes the reward charting and behavior modification. So when we say that behavior modification is about empowering the child to be aware of their problem and take more initiative into it, such as being engaged in linen washing or changing the linens, having more discussion with their parents, so not be shy and shameful about it. And the reward is mostly confined around the behavior rather than the outcome. So they should be rewarded for having more liquid intake or going to toilet at regular intervals, and there should not be any negative criticism or negative reward system in that process. Then it comes to the stage of interventions, and when we talk of interventions, there are a couple of things which start from the alarm, which is enuresis alarm, water sensitive alarm, and that basically works by the moment they have a little drip of urine output, the mattress gets triggered, and it starts creating a loud alarm, waking up the child to go to toilet. And this basically conditions the mind and improves their bladder and brain coordination. The other modalities is medication, which can be desmopressin. It is an external hormone, basically to give an initial surge of vasopressin, which works by diminishing urine production at night, and we all have it, but in these children sometimes this surge is missing. So we give desmopressin externally through oral route, and in other conditions where the bladder overactivity is involved, then we can go for anticholinergics such as oxybutynin or tricyclics. These are the main management modalities, and it depends on what category the child is falling into. So if the child is having lack of arousal, which is not responding to the full bladder sensation, mostly around early morning, then we use the alarm. If it is polyuria, where they are producing urine like a daytime with no surge of vasopressin, then we give external vasopressin in form of desmopressin. And if there is a bladder involved with overactivity or spasm, small functional capacity, then we use anticholinergics and sometimes other medications.